Okay, well, good afternoon, everybody. I don't know how many people are online, but um, this is a brief talk on hepatitis B and HIV, and I'm sure all of you are already familiar with most of this. Um, Hepatitis B is worldwide, it's much more prevalent than hepatitis C. It is estimated about 2 billion people out of the 7 billion worldwide population, about 2 billion have been infected with hepatitis B at some point. Not all of these are chronically infected. It's estimated about 350 million or so are chronically infected. And worldwide, hepatitis B is the leading cause of hepatocellular carcinoma. In the United States, it is hepatitis C, but because of certain areas with a very high prevalence of almost 8% or more, worldwide commonest cause of hepatocellular carcinoma is hepatitis B. Just to give you some background, it's a viral infection. There are 8 genotypes. The commonest genotype in the United States is A. The incubation period after infection is about um, 45 to 180 days. It's a range. I think the important point to remember is that if an adult gets infected with hepatitis B, they are much more likely to clear the virus as compared to an infant or somebody who gets a child who gets infected perinatally from the mother. They have a very high likelihood, more than 90% likelihood of remaining chronically infected. They are unable to clear the virus. So, and by that same token, adults, we are much more likely to clear the virus, and we are much more likely to get jaundice also, suggesting that we mount a inflammatory response to the virus, and so we clear it. Neonates, on the other hand, do not mount an inflammatory response, so they become chronically infected. So let's do this question. 45-year-old man, he has HIV, feels well, CD4 is reasonably okay, CBC, CMP are okay. So what workup do you order? Surface antigen. Brittany, can you see the mouse as I move it? Can you see the pointer?
Yes, I can see the pointer.
Okay, thank you. So you test for surface antigen, core antibody, and surface antibody. Now, some people will not do all of them. I typically just do surface antigen and surface antibody. However, these are the recommendations, that there will be a small subset of people who will have chronic infection, who will not have enough surface antigen, and the only thing detectable will be a core antibody, and they'll still have virus. That's called occult hepatitis B, where you don't have detectable surface antigen, you have a core antibody, and if you do their viral load, they'll have HBV DNA in their blood. That's called occult HBV. Very uncommon. But the two big ones are the surface antigen and the surface antibody. And I'll talk about this in a minute. And surface antigen, if it remains positive for more than 6 months, that's considered chronic hepatitis B. And then you go on to do these other tests, including E antigen, E antibody, HBV DNA, etc. Like I said, most adults will clear the virus. So if I get infected, first thing that goes up is my virus, right? The virus is not shown on the slide. Virus shoots up, the surface antigen goes up, and the core IgM goes up soon thereafter. If I'm going to clear the infection, my core IgM comes down, my core IgM comes down, the total antibody goes up, and the surface antigen then gets converted to surface antibody, right? If I'm not going to clear the infection, then my surface antigen never goes down, and the IgM does turn into a total antibody. So surface antigen, if it remains positive for more than 6 months, that's considered chronic hepatitis B. This is chronic Hep B. This person never cleared the surface antigen. Their IgM did go down, but their total core antibody remained positive, and they'll never have a surface antibody because the surface antigen never converted, and they'll continue to have virus in their blood. Let's just, and I have a couple of cases after this. It's difficult to discuss cases when it's a one-way street. It's not really interactive, but let's just pay attention to this slide. So if surface antigen is negative, core antibodies negative, surface antibodies negative, that means this person has not been vaccinated, because vaccination would give rise to surface antibody. This person has never been infected, because anybody who's infected naturally with hepatitis B will always have a core antibody. So this person should be vaccinated. Next line. The next line is if somebody's surface antigen negative, core antibody positive, and surface antibody positive, that means they were infected. They cleared the surface antigen, their core antibody is positive, and they have surface antibody positive. If somebody's negative for core antibody and positive for surface antibody, that means they got vaccinated, because anybody who got naturally infected will also have this. This positive means they have chronic HBV infection. One of the questions that comes up frequently is, what if this is isolated core antibody positive? Well, it could be different reasons. Number one, resolved infection. That means they got infected, they cleared the virus, but they just did not get enough of a surface antibody. False positive or low-level chronic infection, or also called occult infection. So anytime you have the core antibody positive, you have to assume that they've been infected. The next question comes up, what if somebody's core antibody positive, surface antigen negative, and surface antibody negative? Should you vaccinate? And the answer is yes. So you should vaccinate somebody, even though likely they had natural infection, but because they did not mount enough of an antibody response, vaccination makes sense. Does that make sense so far? Moving on. So what do you think this person has?
I have everyone on mute. Let me see if I can unmute them.
This person is core antibody negative, core IgM negative, surface antigen negative, surface antibody positive. So what does this person have?
He's been immunized.
Sorry?
He's received the vaccine.
Absolutely, he's received the vaccine. How about this person? Surface antigen positive, core antibody positive, core IgM positive. Acute infection.
Yes. Yes.
So acute infection. Very good. So surface antigen is a marker of chronicity. Surface antibody is either vaccination or resolution of natural infection. IgM is acute infection. Total IgG is past or chronic infection. E antigen indicates active replication. E antibody indicates the virus has reduced replication but is still infectious, because the surface antigen is the infectious part along with the virus. The surface antigen is also infectious, and then the virus. So just in the interest of time, I'm going to zip through a few slides. If somebody's Hep B surface, so you have an HIV positive patient, you decide to do hepatitis technologies. You do hepatitis A antibody, hepatitis C antibody, and hepatitis B surface antigen and surface antibody. And their surface antigen is positive, surface antibody is negative. What should you do next? Obviously, you check a CMP, right? I don't check INR in everybody. I think it's a waste. If somebody, unless until they've got cirrhosis, but that's your call. CBC, certainly. In addition, you should consider staging their liver disease. Just like in hepatitis C, we staged liver disease. In hepatitis B, it is not so much a part of the guidelines because treatment is based on the viral load. In hepatitis C, the viral load is meaningless. Excuse me, to the point that we don't rely on we only monitor the viral load during treatment to look for response to treatment. In hepatitis B, the virus actually predicts future cirrhosis, future decompensation, and relation to hepatocellular carcinoma. So in hepatitis B, there is much more of a direct link between the amount of virus and the problems that we get from the virus. Whereas in hepatitis C, there isn't that direct relationship. So in Hep C, we don't really monitor. The Hep C virus is not that prognostic, whereas Hep B virus is. So we try to monitor the virus, but it also makes sense to stage the liver disease. You can do a liver biopsy. You can also do a fibroscan. Remember, as you all know, the fibroscan is a non-invasive way of assessing liver disease, and it can be used for Hep C, where more than 14 kilopascals is considered cirrhosis and less than 7.5 is considered normal. It can also be used for hepatitis B, but it's important to note that the cutoffs for the liver stiffness are different in each population, whether you're checking for Hep B or HCV, HIV, or a non-alcoholic steatohepatitis or alcohol. So it's not the same cutoff. I don't know whether you folks have access to the fibroscan, but in South Carolina, there is no fibroscan in the whole state. And yet, the South Carolina Medicaid wants us to use the fibroscan as the only test for treating Hep C. There is no fibroscan in the whole state. We are purchasing one, and the VA is getting one, but it's amazing. In Hep B, we don't need the fibroscan as much. If somebody has a high viral load, they have transaminitis, you could consider them for treatment, and I'll talk about that in a minute. So the hepatitis B viral load is directly linked to cirrhosis, all-cause morbidity, mortality, and it has also been shown that by bringing the viral load down, by making patients undetectable, you reduce the incidence of cirrhosis, hepatocellular carcinoma, and all-cause morbidity, mortality. So the virus is linked directly to morbidity, mortality from liver or non-liver related causes. So let's talk about this fellow, 45-year-old guy. He's he's got newly diagnosed, or he's got HIV, never been on treatment. CD4 is 4,500. Viral load is 150,000 copies. ALT is okay. E antigen positive, E antibody negative, and his viral load is 10 million. Would you like to treat this fellow for his Hep B? You can just raise. Oh,
And Brittany showed up our pick girl with the.
sorry. Yeah, I think somebody said yes, and I agree, right? You know, you want to treat, because you're going to treat the HIV, you'd want to treat the hepatitis B at the same time. And it's actually easy for us in the HIV world to treat hepatitis B, because one of our best drugs, like Josie showed in her presentation, which she's going to show in a few minutes, it works beautifully. So what are the indications for patient treatment? Any cirrhotic, anybody with end-stage liver disease with hepatitis B should be treated. Anybody with HIV co-infection should be considered for treatment. Anybody with hepatitis C should be considered for Hep B treatment. Older people, and I disagree with this definition of older. For me, it's a different age, but that aside, older people, anybody with a family history of Hep B cirrhosis or hepatocellular carcinoma, Hep C co-infection, HIV co-infection should be considered for treatment. Therefore, this fellow qualifies for treatment. He has HIV, he's 45, you are going to treat his HIV, and so you're going to treat his Hep B at the same time. And why should you treat? There are long-term benefits: cirrhosis, cancer, death. The primary goal is to bring the viral load undetectable. Secondary goals are to normalize transaminase, induce E antigen to E antibody, induce surface antigen to surface antibody, and improve the liver cirrhosis or liver disease. There are two distinct patient populations. E antigen positive. In the United States, it is estimated about 60 to 70% of chronic Hep B patients are E antigen positive. About 30 to 40% are E antigen negative in the US. These are so-called pre-core and core promoter mutants. So the goal in an E antigen positive patient would be to make the E antigen to E antibody, make their viral load undetectable, and to normalize their ALT. This is the basic bottom line. E antigen positive patients are treated if their ALT is twice the upper limit of normal, or their Hep B viral load is more than 20,000 copies or 100,000 international units. I don't know whether I'm rushing through slides, but I think we're still okay. Another 5 minutes, I'll be done. We don't use interferon anymore, right? You could, but we have other drugs. 3-TC or lamivudine. Remember, the dose in HIV is what? 300 milligrams a day. Interesting. I don't have tenofovir on this. I should have tenofovir on this. Entecavir or Bariclude and telbivudine. And then adefovir and then tenofovir. Both entecavir and tenofovir are good options. This is patients at 1 year who were treated with entecavir, and this is the group with tenofovir, and a similar percentage, about 21 to 25% at 1 year, will convert their E antigen to E antibody. Most of these patients will become undetectable. Only a small minority convert from surface antigen to surface antibody. That is very rare. And these are E antigen conversion rates over a period of time. This is a mixed group of patients, and you can see at 1 year, most of your patients who are hepatitis B E antigen positive, 21 to 25% of your patients who are E antigen positive will lose their E antigen and will become E antibody positive. And that percentage continues to climb over the next 2 to 3 years. Okay. How about the viral load? The viral load at 1 year of treatment becomes undetectable in 75% of tenofovir treated patients, about 70% of Bariclude treated patients. This is entecavir. So entecavir 70%, tenofovir about 75%. This is E antigen positive. In E antigen negative patients, a higher percentage will become undetectable by 1 year because they started off with a lower viral load. But a couple of caveats, and I'm sure you're all aware of it. Do not use lamivudine as monotherapy. Lamivudine works beautifully on the Hep B virus. However, at 1 year, 10 to 20% have developed resistance. By 2 years, 40%, and by 4 years, 90% of patients on lamivudine monotherapy will become resistant. So don't use it as monotherapy. Use it in combination with tenofovir in the form of Truvada. So let me just see. How do you monitor these patients? For example, your patient, Josie, you sort of, I didn't get time to go through the presentation. Both you and I sent it at the last minute. So, but that's okay. But I think your patient is on Atripla, right? And I think you still did not have follow-up labs, but you can present that in just a minute. So let's just take a step back. HIV infected patient, you decide to treat. You use a Truvada-based regimen, so therefore you cannot use Triumec, right? Triumec does not have Truvada. It's got abacavir, lamivudine, and dolutegravir. You could use Stribild, which has Truvada. You could use Atripla, you could use Complera, or you could use Truvada plus a protease inhibitor, right? That way you're treating the HIV very well, and you're also treating the hepatitis B. You would have staged them, you would have checked their viral load at the beginning, check their ALT, AST, E antigen, and then you follow them every 12 weeks. In 12 weeks' time, their viral load should have come down. And they should be undetectable within 6 to 12 months. The E antigen should convert to E antibody. You remember I just showed you numbers, about 20 to 22% will go from E antigen to E antibody within the first year. And over the next 2 to 3 years, more will lose their E antigen, more will become E antibody positive. If their viral load doesn't go down, then you need to consider resistance. Supposing somebody comes to you and has already been treated for HIV with, let's say, Trizavir. Trizavir is abacavir, lamivudine, and AZT. Maybe they have lamivudine resistance. Maybe the hepatitis B virus has developed lamivudine resistance because it was getting monotherapy, right? So in patients who have already been treated with lamivudine or emtricitabine, you might need to consider testing HBV resistance at baseline. Okay? So you might need to consider HBV resistance testing at baseline. And if you're going to treat the HBV, you might need to do it with 2 drugs. For example, you might need to use entecavir and lamivudine. So previous treatment experience is very important. If somebody's seen lamivudine or some kind of 3TC or FTC monotherapy, their HBV could very well have become resistant, because as I just showed you, over 40% will be resistant by 4 or 5 years, and up to 60-70% in 5 years. So you have to consider testing the HBV for resistance. Alcohol, obviously avoid. Vaccinate against hepatitis B, check for hepatitis C. Like I said, HBe antigen seroconversion in 1 year in about 20-25%. Surface antigen doesn't clear easily. Surface antigen is less than 3% seroconversion to surface antibody. The viral load will come down. In the majority of your patients, their viral load will become undetectable within 3 to 6 months. And you continue to follow that viral load. And then vaccinate, right? I'm not going to talk to you about vaccination. Last thing, the 2 big elephants in the room are, number 1, if somebody goes undetectable on treatment, their HBV virus, and if their surface antigen goes from surface antigen to surface antibody, are they cured? And the short answer is no. Even in somebody who goes from surface antigen to surface antibody, their E antigen has gone to E antibody, their viral load is undetectable, they can still harbor the virus within the hepatocytes, within the nucleus. Remember, hepatitis B and HIV both have intranuclear phases, whereas hepatitis C only passes through the cytoplasm, so it can be easily cured. Hepatitis B forms that cccDNA, and so we cannot eradicate it. Even if all their numbers look good, their viral load is undetectable, surface antigen has gone to surface antibody, even then, that is called a functional cure. If you were to take their liver and mash it up and look for hepatitis B, there will be Hep B virus sitting there. So, essentially, we cannot completely cure hepatitis B, number 1. And the second point is duration. Duration is tricky. Because we cannot cure it completely, a lot of people get placed on lifelong treatment. And that is why, before you start treatment, think about whether the person really needs it. Because if you have a 22-year-old person and you doom them to lifelong treatment for Hep B, I think that's quite, that's important. That's a bit much. If it's a 60-year-old person with other comorbidities, HIV, etc., then certainly place them on treatment. Because even now, it is not clear when you can discontinue therapy. That becomes a little tricky. So be careful when you start. Check the viral load, check the AST/ALT, check an ultrasound, consider doing liver fibrosis staging, and then go on to and then treat